So, what is puberty? Puberty in girls is the period which links childhood to adulthood. This is the period of gradual development of secondary sexual characters. Morphological changes. These are described by Tanner and Marshall. There are five important physical changes that are evident during puberty. These are breast, pubic, axillary hair growth, growth in height, and menstruation. So there are five. First is breast development, second is pubic hair development, axillary hair development, growth in height, and menstruation. Most of the changes occur gradually, but only the minority can be dated. Moreover, there is a lot of variations in the timing. The most common order is beginning of growth spurt. First is growth spurt, then is breast budding, that is known as thelarchy, then is pubic and axillary hair growth, that is adrenarchy, and then is peak growth in height, and then will be menstruation. Growth spurt, breast budding, pubic and axillary hair growth, peak growth in height, and then is menstruation. All these changes are usually completed in between 10 to 16 years. Important controlling factors for onset of puberty is genetic, nutrition, body weight, psychological state, social and cultural background, exposure to light, and others. Endocrinology in puberty. The levels of gonadal steroids and gonadotropins are low until the age of 6 to 8 years. This is mainly due to negative feedback effect of estrogen to hypothalamic pituitary system. So, until the age of 6 to 8 years, the estrogen gives the negative feedback to the hypothalamic pituitary system. The gonadostats remain very sensitive to the negative feedback effect even though the level of estradiol is very low during that time. So, gonadostats which are very sensitive 6 to 15 times will respond even at the low level of estradiol. As puberty approaches, this negative feedback effect of estrogen is gradually lost. This results in some significant changes in the endocrine function of the girl. So, hypothalamo-pituitary gonadal axis. Hypothalamus secretes GnRH that will result in pulsatile gonadotropin secretions, that is GnRH will release gonadotropins and this will in return will release estradiol. The tonic and episodic secretion of gonadotropin in pubertal period is gradually changed to one of the cyclic release in postpubertal period. So, in prepubertal period, gonadotropin secrete in tonic and episodic secretion, and after puberty, they secrete in cyclic release. Thyroid gland also play a role in the hypothalamo-pituitary gonadal axis. Adrenal glands will increase the activity of sex steroid synthesis. Androstenedione, the sex steroids synthesized by adrenal gland are androstenedione, DHA, DHES. from about 7 years of age. Increased sebum formation, pubic and axillary hair, and change in voice are primarily due to adrenal androgen production. So, the increased sebum formation, pubic and axillary hair, and the change in voice, these are primarily due to adrenal androgen production. Now is gonadarchy. This means increased amplitude and frequency of GnRH which will result in increase in secretion of FSH and LH, which will result in ovarian follicular development, and these ovarian follicles will secrete estrogens. Gonadal estrogens are responsible for the development of uterus, vagina, vulva, and the breast. So, estrogen is responsible for the development of uterus, vagina, vulva, and breast. Now is leptin. Leptin, this is a peptide that is secreted in the adipose tissue, is also involved in pubertal changes and menarche. So, the endocrinology in puberty has five factors. First is hypothalamic pituitary gonadal axis, thyroid gland, adrenal gland, leptin, and gonadarchy, which is increased estrogen, result in uterus, vagina, vulva, and breast development. Adrenal glands, the hormones secreted, the sex steroids secreted by adrenal gland will result in sebum formation, pubic and axillary hair, change in voice. Now, what is menarche? Onset of first menstruation in life is called menarche. It may occur anywhere between 10 and 16 years, so the peak time being 13 years. There is endometrial proliferation due to ovarian estrogen. But when the level of estrogen will drop temporarily, the endometrium sheds and bleeding is visible. So, the bleeding occurs due to estrogen level drop. It denotes an intact hypothalamo-pituitary ovarian axis, functioning ovaries, presence of responsive endometrium to the endogenous ovarian steroids, and the presence of patent uterovaginal canal. So, when the first menarche appears at this time, this will representing as that the hypothalamo-pituitary ovarian axis is functioning absolutely fine. Presence of responsive endometrium to the endogenous ovarian steroids, and there is patent uterovaginal canal. First period is anovular. The periods may be regular, but the ovulation may be irregular, and it may take about 2 years for regular ovulation to occur. Growth in height in an adolescent girl is mainly due to hormones. The important hormones are growth hormone estrogen, and insulin like growth factor 1. Bone or skeletal age is determined by x ray of hand or knee. So, if we want to calculate the bone or the skeletal age, we will see the x ray of hand or knee. Genital organ changes, ovaries change their shape, elongated shape becomes bulky and oval. The ovarian bulk is due to follicular enlargement at various stages of development and proliferation of stromal cells. So the ovaries change their shape, they become oval and they become elongated because they become bulky. They become bulky because of follicular enlargement and the proliferation of stromal cells. The uterine body and the cervix ratio at both is 1 is to 2, and then the ratio becomes 1 is to 1 when menarche occurs. Thereafter, the enlargement of the body occurs rapidly so that the ratio soon becomes 2 is to 1. So, at both, it is 1 is to 2. After menarche, it is 1 is to 1. And then, after some time, it becomes 2 is to 1. The vaginal changes are more pronounced. A few layers of thin epithelium in a child become stratified epithelium of many layers. These cells are rich in glycogen due to estrogen, so the uterine bacilli appear which convert glycogen into lactic acid, and the vaginal acidic pH is ranging between 4 and 5. Vulva is more reactive to steroid hormones. Mons pubis and labia minora increase in size. Breast changes are pronounced under the influence of estrogen. There is marked proliferation of duct system and deposition of fat. So the breasts become prominent and round under the influence of progesterone. There will be development of acini increases considerably. So the estrogen is responsible for the development of duct system and progesterone is responsible for the development of acini. Now tenor staging. According to tenor, breast and pubic hair development at puberty are divided into 5 stages. So let's study the tenor staging. What are the changes in the breast and pubic hair? Stage 1, prepubertal state, there will be elevation of papilla only. No pubic hair present in stage 1. Stage 2, breast buds. Papilla slightly elevated and side of labia areola begins to enlarge. Sparse long hair on either majora. Further enlargement of entire breast tissue. Pubic hair become darker, coarse thicker and curly over the mons pubis. Secondary mound of areola and papilla projecting above the breast tissue. Adult type of hair covering the mons only. Areolar recess to general contour of breast. Adult hair with an inverse triangle. These are distributed in inverse triangle covering the medial thighs, and there will be hair on medial thighs also, and this growth is known as So this is at both, at menarche 1 is to 1, nulliparous 2 is to 1, menopause it regresses, it regresses. So as you can see, there is equal cervix, large uterine body, small cervix, 2 is to 1 ratio, again 1 is to 1 ratio. Common disorders of puberty that we will study is precocious puberty, delayed puberty, menstrual abnormalities, that is amenorrhea, menorrhagia, dysmenorrhea, and others like infection, neoplasm, hirsutism, etc. So first we will study precocious puberty. Definition: the term precocious puberty, as for girls who exhibit any secondary sex characteristics before the age of 8 or menstruate before the age of 10. So what means precocious puberty? That the secondary sexual character will appear before the age of 8 and the menstrual period will begin before the age of 10. Precocious puberty may be isosexual where the feature of due to excess production of estrogen. It may be heterosexual where the features are due to production of androgen. So this is modern. The precocious puberty that may be isosexual due to production of estrogen and heterosexual due to the production of androgen from ovarian and adrenal neoplasm. Now, types or causes of precocious puberty: GnRH dependent and GnRH independent. GnRH dependent 80%. This will result in complete, central, isosexual or true. Constitutional, juvenile primary hypothyroidism, intracranial lesions. Incomplete, premature thelarchy, premature pubarchy, premature menarche. This is due to excess estrogen or androgen, precocious pseudopuberty or peripheral. In ovary, it is due to granular cell, theca cell, Leydig cell, chorionic epithelioma, endoblastoma. These are the reasons: adrenal hyperplasia, tumor, hepatoblastoma. So these are the causes. Constitution: etiology of precocious puberty. Constitutional: it is due to premature activation of hypothalamo-pituitary ovarian axis. There is secretion of gonadotropin, gonadal steroids due to premature release of GnRH. Bone maturation is accelerated, leading to premature closure of the epiphysis and cortical stricture. If menstruation occurs, they may be ovulatory. The change in puberty progresses in an orderly sequence. Due to intracranial lesions like meningitis, encephalitis, craniopharyngioma, and neurofibroma or any tumor, hypothalamic opinion gland. McCann's-Albright syndrome is characterized by sexual precocity, multiple cystic bone lesions, endocrinopathies, capillary spots on the skin. Sexual precocity. So, McCann-Albright syndrome consists of sexual precocity, multiple cystic bone lesions, endocrinopathy, and these spots which are present on back of this trunk. Sexual precocity is due to early and excessive So the sexual precocity is due to estrogen, early and excessive estrogen production from the ovaries. FSH and LH levels are low. There may be associated hyperthyroidism, hyperparathyroidism, and acromegaly. So these are the endocrinopathies: hyperthyroidism, hyperparathyroidism, and acromegaly. What is premature thelarchy? Premature, we will say premature thelarchy if the breast tissue developed before the age of 8. Either one of the breast may be enlarged. There is no other feature of precocious puberty. It requires no treatment. Premature puberty. It is isolated development of axillary or pubic hair prior to the age of 8 without other signs of precocious puberty. The premature hair growth may be due to unusual sensitivity of end organs to the usual low level of hormones in the blood. It is due to unusual sensitivity. Rarely there may be signs of excision. Rarely there may be excess androgen production due to adrenal hyperplasia or due to androgenic ovarian tumor. These are Leydig cell endoblastoma. Premature menarche. Premature menarche is an isolated event of the cyclic vaginal bleeding without any other signs of secondary sexual development. The cause remains unclear but may be related to unusual endocrine sensitivity, maybe due to under of the endometrium to the low level of estrogens. Chorionic epithelioma, hepatoblastoma are the ectopic sources of human chorionic gonadotropin and mucosal sexual precocity. So, what is diagnosis? For true precocious, that is constitutional type, is the commonest one, but the rare one is to be kept in mind. The diagnosis is made by history of early menarche of mother and sister. The pubertal changes occur in orderly sequence. 10 stages, no cause could be detected. The basic investigation to confirm or exclude the pathological lesions: X-ray hand or wrist for bone age, pelvic sonography to exclude ovarian pathology, skull X-ray, CT scan to exclude intracranial lesion, serum HCG, FSH and LH to exclude the pregnancy, thyroid profile, serum estradiol testosterone to rule out the adrenal pathology, and electroencephalogram. Premature thelarchy. Somatic growth pattern is not accelerated, bone age is not advanced, nipple development is absent, vaginal smear shows negative estrogen effect. Premature puberty and ovarian enlargement may not be palpable clinically, but examination under skin is helpful. CT scan is required to detect adrenal tumor, estimation of serum. Premature menarche. The other cause of vaginal bleeding, such as foreign body or injury, has to be excluded. If the bleeding is cyclic, the diagnosis is confirmed. Investigation must be carried out to rule out any pathology in the CNS, ovary, and adrenal. It should be borne in mind that even in cases when no cause can be detected in any of the types mentioned, the periodic evaluation at 6 monthly intervals is to be made to detect any life-threatening pathology. Treatment of precocious puberty depends upon the cause. Exogenous estrogen therapy or its intermittent intake should be stopped for by cortisone therapy for adrenal hyperplasia or and surgery to remove the adrenal or ovarian tumor, eliminate the excess source of cortisone therapy or surgery of the ovarian tumor or adrenal. The intracranial tumor requires neurosurgery or radiotherapy. Intracranial tumor have the neurosurgery and radiotherapy. Primary hypothyroidism, thyroid replacement therapy. Constitutional idiopathic type to reduce gonadotropin secretion, to suppress gonadal steroid growth rate, to protect the girl from sex abuse. The drug used are GnRH agonist therapy arrests the pubertal precocity and growth velocity. The agonists suppress premature activation of hypothalamo-pituitary axis due to downregulation and thereby diminished estrogen secretion. GnRH agonist therapy is the drug of choice in cases with dependent precocious puberty, therapy should be started as soon as the diagnosis is established. GnRH agonist therapy suppresses FSH-LS secretion, reverses the ovarian cycle, establishes amenorrhea, causes regression of breast, pubic hair changes, and the other secondary sexual characteristic. GnRH agonist therapy suppresses FSH-LS, reverses the ovarian cycle, establishes amenorrhea, causes regression of breast, pubic hair changes, and other secondary sexual characteristics. This drug should be continued till the median age of the puberty. Now, buserelin nasal spray, 100 microgram daily. It can slow down the process of skeletal maturation, depot forms. Goserelin or leprolide once a month can be used. Dose is adjusted to maintain the serum estradiol below. Okay. These are given according to the same serum estradiol below 10 kg. Medroxyprogesterone acetate 30 mg daily orally. IM weekly to suppress gonadal steroids. It can suppress menstruation and breast development but cannot change the skeletal growth rate. Kryptonate acetate, it acts as a potent progestogen, having agonist effects on the progesterone receptors. Dose orally for 10 days, starting from danazol, amenorrhea, respiratory development, but there is no effect on the growth rate or skeletal maturation. Duration of therapy, drug should be used for up to the age of 11 years. However, individualization is to be done. Prognosis. With primary hypothyroidism, puberty is said to be delayed when the breast tissue or pubic hair have not appeared by 13 to 14 years or menarche appears as late as 16 years. So what is delayed puberty? If the breast tissue and the pubic hair are not developed by 13 to 14 years or there is no menarche as late as 16 years. The normal upper age limit of menarche is 15 years. Causes of delayed puberty: hypergonadotropic hypogonadism, hypogonadotropic hypogonadism, eugonadism. So, gonadal dysgenesis, pure gonadal dysgenesis, ovarian failure. Constitutional delay, chronic illness, malnutrition, primary hypothyroidism, isolated gonadotropin deficiency, intracranial lesions. Anatomical causes like these: androgen sensitivity syndrome. Treatment is directed according to the etiology. Improvement of general health and treatment of any illness may be help in endocrinal causes. Cases with hypogonadism may be treated with cyclic estrogen. Unopposed estrogen daily is given for first 6 months, then combined estrogen and progesterone sequential regimen is started. Cases of hypogonadism should have chromosome 2. Puberty, menorrhagia. Menstrual abnormality in adolescents are common. The period may be heavy, irregular, or scanty initially. Important causes of menorrhagia: dysfunctional uterine bleeding. What is pubertal menorrhagia? Menstrual abnormality in adolescents are common. The periods may be heavy, irregular, or scanty initially. Periods are heavy, irregular. Eventually, the majority of these teenage girls establish a normal cycle and are fertile. The causes may be dysfunctional uterine bleeding, anovulatory cycles, unopposed estrogen, endometrial hyperplasia, prolonged and heavy periods. So there are an ovulatory cycle, no corpus luteum, no progesterone, unopposed estrogen. Estrogen causes endometrial hyperplasia, prolonged and heavy periods. Endocrine dysfunction, polycystic ovarian syndrome, hypo and hypothyroidism. Hematological, so this cause in hypo and hypo both. Idiopathic thrombocytopenic purpura, von Willebrand disease, leukemia due to deficiency of platelets, and von Willebrand disease. Pelvic tumor, fibroid uterus, sarcoma, estrogen producing ovarian tumor, pregnancy complications. Diagnosis, careful history taking, clinical examination, evaluation is specially indicated if the menstrual interval is to less than 22 days, greater than 44 days, lasts longer than 1 week, or the bleeding lasts longer than 1 week, or the bleeding is too heavy that the anemia develops. Investigation planned according to the clinical diagnosis. Investigation include routine hematological examination, include bleeding time, clotting time, platelet count, thyroid profile, clotting profile, imaging study of the pelvis by ultrasonography. Uterine curettage are rarely needed to exclude any pelvic pathology. The curated material is said to histopathological study. Management, adequate explanation, reassurance, psychological support, rest and correction of anemia are helpful in majority of the cases. Therapy with hematinics or even blood transfusion may be needed. In refractory cases, progestogen such as medroxyprogesterone acetate or norethistrin, norethisterone 5 mg thrice daily is given till bleeding stops. Usually the bleeding is controlled within 3 to 7 days. Medication is continued for 21 days. This condition usually becomes normal following 2-3 courses and the normal cycles resume. After 2-3 courses it will be resumed. It will be in emergency and conjugated equine. In emergency we will give conjugated equine estrogen every 6 to 8 hours. Once the bleeding is controlled, combined oral pills are started. Regular menstrual cycle will be established once the is mature. Management protocol of rest assurance hematinics. Heavy bleeding continues. Admit for investigation, hemoglobin, peripheral blood film, platelet count, loading factor study, ultrasonography, thyroid profile, blood transfusion. Primary, in primary we will give progestin therapy, medroxyprogesterone acetate 10 to 20 mg per day. If it is responsive, we will continue for 2-3 cycles. If it is unresponsive, we will give conjugated estrogen 20 to 40 mg IV every 6 to 8 hours. If responsive, replace therapy with combined oral pill. If it is unresponsive, then an curettage biopsy. If secondary to thyroid dysfunction, ITP, leukemia, von Willebrand disease,